Hi, I'm Dr. Christina Wu. I'm a medical oncologist who specializes in treating gastrointestinal cancers, specifically with a research focus in colorectal cancer here at Emory University Hospital, Winship Cancer Institute. I'm here to talk with Dr. Christie about colorectal cancer.
Hello, my name is Dr. Jennifer Christie, and I'm Clinical Director of Digestive Diseases for the Emory Clinic. So March is Colon Cancer Awareness Month. And over the next 15 to 20 minutes, Dr. Wu and I are going to talk about diagnosing colorectal cancer, treating it, and the importance of screening and prevention. We are also happy to take questions in the comment section at the end. So Dr. Wu, what is colorectal cancer, and how many people are diagnosed each year?
So colorectal cancer is cancer that has developed anywhere along the GI tract, from the colon all the way down to the rectum. The pathology that we usually see is called adenocarcinoma, and that's how we define colorectal cancer. So colorectal cancer is the third most common cancer in the U.S. for men and women. There is an estimate of 148,000 new cases in 2020 alone, and 53,000 deaths related to colorectal cancer in the last year. Here in Georgia, 4,500 new cases will be diagnosed in the year. And so a large patient population have colorectal cancer. What the good news is that with the screening practices, including colonoscopies, there's actually been a decrease in the incidence of colorectal cancer. And we really believe that's because we're catching them early in the form of polyps before they become cancer. And so those efforts have really paid off.
Good.
What's striking and more interesting and alarming is that younger patient populations are now being diagnosed with cancer, young and meaning age 20 to 39, and we don't really know why. Want to know what you're seeing in your clinic.
Yeah, absolutely. We are seeing that younger patients are being diagnosed with colorectal cancer, and we're really still trying to figure that out. There are a lot of things that we know may be playing a role in that, and a couple of those things include we know that obesity plays a role in increasing the risk of colon cancer incidence, and so really adhering to diets that are low in fat, higher in fiber, fresh fruits and vegetables are going to be key in terms of reducing risk. Also, things that we can change that are modifiable, and we know that more than 50% of colon cancer patients have modifiable risks. And so, in addition to diet and weight, exercise is key. So we know that it is so important to exercise on a regular basis, and that's going to reduce your risk for a lot of chronic diseases and many cancers. Additionally, smoking increases the risk for many cancers, including colon cancer. So we want to stop that. Talk to your doctor about smoking cessation or stopping. Heavy alcohol use is associated with increased risk of colon cancer. And then interestingly, we also know that, or we're thinking that the changes in the microbiome may be playing a role. Exactly how that's happening, we're not sure, but when I say microbiome, I'm referring to the gut flora, the bacteria in the gut that we all have, but there may be something different as far as the combination that is increasing the risk, and it may be triggering some changes that cause colon cancer to form. So we're really looking at what that could be, and then how we can change that. So in terms of that risk factor, so diet's going to be key, and then of course there are risk factors that are not modifiable. For example, genetics and family history. So tell me what you're seeing in terms of family history and how that could be playing a role in colon cancer.
That's a really great question. Almost 30% of our patients who have colorectal cancer have some sort of family history. And so I do think that's essential when we're trying to figure out if people are high risk or not. There are hereditary syndromes such as Lynch syndrome, or FAP, which stands for familial adenomatous polyposis. Although these are small in percentages, they're very significant. And so when we have identified patients who carry that trait, their screening practices are going to be very different from the recommended screening guidelines that we usually have. So to ask you a question, what age should we start screening?
So currently, the American Cancer Society recommends that all patients, all individuals, start screening at age 45. This is a little different from a few years ago when we said that the recommended screening age was 50, but now the thought is that starting at 45 is important. Again, going back to that question around seeing it at a younger age. So maybe we have to start looking for it at a younger age as well.
So what are patients we would consider high risk?
Yes, great question. So the patients that are high risk, we know that African Americans have a higher incidence of and death from colon cancer. So all African Americans should start screening at age 45 for sure. Additionally, we know that patients who are from the Eastern European area, Ashkenazi Jews, are actually at increased risk for colon cancer as well. They have actually the highest incidence worldwide, so that's really key. Other patients who may be at higher risk are patients who have a history of polyps themselves, right? Of course, who have had colon cancer themselves and other types of cancers. And then also patients who have inflammatory bowel disease, so that's Crohn's disease and ulcerative colitis. Those patients should definitely start screening a lot earlier and have regular colonoscopies to look at the colon. And then you mentioned family history as well, so that's going to be important.
I've been recommending patients to have their first degree relatives start at a younger age from the time they were diagnosed.
Yeah.
So that's definitely something that we think about.
Absolutely.
What are the different screening methods that we have available?
So there are three main screening methods that we're recommending. Of course, there's others that are not used as commonly these days, but the three main screening methods that we have include the stool based test looking for blood in the stool, and that's called the FIT test. Many of you may have heard of that from your referring your providers, and that's usually done every year. And then there's the stool-based DNA test, and that test looks for DNA or genetic mutations that may be found in the stool that come from colon cancers, and that's a relatively new test. And the last test that I want to mention is colonoscopy. So colonoscopy is both diagnostic; it can diagnose polyps and cancers, and then it can remove polyps. And so during that particular test, we can remove polyps early before they can grow and turn into colon cancer. We know most cancers start from a polyp. So if we can get those polyps out early and take them out, then we're going to significantly decrease your risk. And that's done on a regular basis as well, depending on whether it's normal or if you've had polyps in the past. So it's really important that patients talk to their doctors about how often you should have any of those tests done.
And to your point, if you have a positive stool test, you have to go get a colonoscopy.
Oh, absolutely, yes.
Yeah.
Yes, thank you for that. Yeah, so if you have a positive stool DNA or a stool blood test, it has to be followed up with a colonoscopy to see why that test is abnormal. Absolutely. Yeah. So, Dr. Wu, tell me, what are some of the signs and symptoms of colon cancer?
So they can be pretty insidious, slow in progress. It can just initially be a change in bowel movement, where if you are someone who is very regular with your bowel movements, suddenly you can have constipation where it's difficult to have a bowel movement where you're straining. Or it can even go the other way where you suddenly have very loose stools, watery stools, and frequent. So it's not always clear as to what kind of symptoms you have. Other things that we definitely should ring alarm bells are blood in your stool. A lot of people think they're just hemorrhoids, but we don't know for sure until you have a colonoscopy. So I do think that if you have any blood in your stool, that you have to see your doctor to talk about why it is that you're having blood in your stool. Actually, some people also find it on blood tests, routine annual blood tests, where they notice that people have a low hemoglobin or anemic, and that is indicative of blood loss somewhere. So that's another thing that we really have to look look out for. Our primary care physicians, family practitioners should know that we should be looking into anemia causes. And then finally, people can have abdominal pain, just non-specific, or they may have cramping or having pain that's persistent that doesn't go away, as well as weight loss, unintentional weight loss. Suddenly weight's coming off of you without much of an effort. These are all sort of warning signs that we should figure out what's going on and consider a colonoscopy. And to be honest, a lot of my patients enter my clinic without any symptoms. A lot of them come and it's a screening colonoscopy where they went for their annual colonoscopy and very early stage cancer was found. So you could also have no symptoms at all.
Yeah, that's actually, I would say, a good portion of our patients. So that's really important. So tell us, how do you and your team treat colon cancer, and what are some of the new developments at Winship?
So it's a very exciting time for colorectal cancer. I was really happy to hear you talk about microbiomes because a lot of the conferences now are talking about understanding the interaction of how our body and how our food and how the stool is going. So we're still a lot to be known, but we actually, a lot of clinical trials, we're collecting stool because we're trying to understand what's going on.
We like stool.
Yes. So for people who have early stage cancer and they've had surgery to have it resected, they often come to us in oncology to figure out if we want to offer chemotherapy afterwards and how can we improve our chances of this not coming back. So there's a lot of work being done on, if there's supplementation, if there are other things that we can add to decrease that recurrence rate, not just looking at chemotherapy. For patients who unfortunately do have metastatic cancer, we're looking at different targeted therapy. So that's things like high levels of a certain protein, for example, one called HER2, which is known in breast cancer. We actually have a trial where we target that. And so there's a lot of development in that as well. In the lab, we're trying to understand more about the role of immunotherapy and colorectal cancer. Patients who have a certain feature called macrosatellite instability, we know are very sensitive to immunotherapy, but unfortunately that's not the main population that we have, and we're trying to understand why that is. So we have trials to see if we can make patients sensitive to immunotherapy. We also have a trial looking at vitamin D supplementation to chemotherapy to see if people will benefit from that. So there's a lot of things that we're still looking into.
Very exciting.
So just to say, if anyone is interested in getting an appointment or having an evaluation here at our GI Oncology Clinic at Winship, feel free to call us at 404-778-1900. Christy?
And if anyone is interested in seeing one of our GI doctors, our gastroenterologists, or you want to set up a screening colonoscopy, please call us at the Emory Clinic, 404-778-3184.